Yeah, thanks, Sayan. Chennai is my hometown, so it's obviously a place which should be easy for me normally to get to, but today I can't be there. Sorry to miss it, and also for the opportunity to be at IIT Madras. So I'm going to talk about. So Madhav, I only caught the last couple of slides of your talk, so I don't know what else you spoke about, but I'm going to talk mostly about COVID epidemiology in India, and so I'll just share my slides here. So, so this is work that was done by many people, and this was published in a set of so far three papers. The fourth one is forthcoming, and it really is based in Tamil Nadu for a large part. Chennai, Madurai, and also overall Tamil Nadu. And we were fortunate to be able to work with the Tamil Nadu government on all of these studies. The very first, and remember, this is sort of an evolving situation because these studies were done at various times in the epidemic when that's all we really knew. And in the beginning, we knew very little. This first paper was published by August of 2020. You remember the COVID epidemic, in India started only, February of 2020. So this was a very early paper by August, which told us a lot about transmission dynamics of COVID-19 and in Andhra Pradesh and Tamil Nadu. So in some sense, some of the stuff maybe, things that you already know because you read about it in the papers and all of that. But this was the first large study. In fact, this was the largest COVID study in the world, and still is in terms of number of, people tracked and so forth. So, and it was published, it was written up widely. Basically relied on data where 3 million people were traced, and there were reliable data on 575,000 contacts and 84,000 primary cases and 5,000 deaths, 5,700 deaths. Now, previously, the previous largest contact tracing study was 10,000 people, and this was out of South Korea, and this was the largest study done for any disease, in fact. So to go from 10,000 to 575,000 was a pretty big jump, but it was made possible because Tamil Nadu, Andhra Pradesh had the apparatus from HIV to go and actually do contact tracing. If someone was infected, to see where they might have gotten infected from. In that respect, India was way ahead of any country. We also do these studies in the US, in the state of Maryland, and we didn't have anywhere close to this kind and quality of data there. Now, you all know how the pandemic proceeded. 2020, you had fewer cases. By June, you had more, and by July, you had many more cases, mostly originating from the urban centers. Tamil Nadu had an earlier epidemic than Andhra Pradesh, but Andhra Pradesh also soon caught up. At their peak, Andhra Pradesh at that time was testing as much per capita as the United States. So the level of testing here was truly impressive. And what was also impressive was that Tamil Nadu was not using any antigen test. It was only using RT-PCR test, something it stuck to right from, throughout. Now, this was the earliest study where we knew something about the secondary attack rate, which is about 7.5. What we also realized from this study was that travel was a major reason for a higher secondary attack rate, 79, and households had a secondary attack rate of about 9, which means that for every 100 people exposed in a household setting, about 9 of them would actually get infected. This 9 is remarkably close to this number that was discovered in South Korea as well as in China, which was reported prior to ours. 9 or 10 household contact secondary attack rates. And that was interesting because what we were seeing back in 2020 itself was a remarkably consistent picture of COVID. Now, this is a picture that captures a lot of information. And in fact, I've taken it out of The Economist magazine because they did a better picture than our own paper did. And on this axis, you have the age of people subsequently infected, but this is the age of the infected person. What you see is that people in their 20s were the ones who were the primary cause of infection, and they were infecting people across all ages, starting from the elderly, down to the very young. What you see is that everybody was infecting somebody, although it was not that big of an infection, but young adults were really the big spreaders to all age groups. Now, you also see this dark shaded 45-degree line, or whatever it's I guess it's 90 degrees here, which basically is that everyone was infecting people mostly in their own age group. And we see this kind of cohorting effect by age in India for many things. But, you think of India as really having multi-generational households, but that's not necessarily the case. You actually see a lot of association between, 80-year-olds tend to hang out a lot more with 80-year-olds and so forth. Now, super spreading. So super spreading, we tend to think of super spreading as really one person, transmitting to 50, 100,000 people. And there were those kinds of events across India. We know we had the Tablighi Jamaat event in Coimbatore market, and in Chennai, we had a super spreading event. But this is not the topography of super spreading events. Obviously, some of them happen in medical facilities, prisons, homes, but we don't necessarily capture all of these unless we have very good testing. And these have been discovered around the world. In our study, what we found was that 70% of people who tested positive did not infect anybody else. And about 60% of subsequent infection were caused, actually not by 10, more like 9% of people. And so you had very, very few people infecting, causing most of the infections. Now, this has also been seen in a study from Hong Kong. This was an event where someone in a social event transmitted to many people, and then they went on to transmit to families. But remember, this is an unusual kind of an event. What you see much more of super spreading is basically where one person is spreading to 3, 4, 5 people. And that is really also, the sort of thing which makes the epidemic sort of go much further. Now, an outbreak in a ski village in Austria was linked to cases in 45 different countries. This was a classic super spreading event. This was very early in the pandemic. And the classic typology of super spreading is you have a homogeneous population, but super spreading is when the proportion of infectious cases ranked, and the expected proportion of transmission are not a 45-degree line. So SARS was a classic case of super spreading. And this dispersion parameter K, this K parameter for COVID was much closer to SARS than it was to any of these other diseases. Now, the advantage of super spreading, if there is any, is that you can have targeted control policies better than population level policies, provided we have positive correlates of predictive correlates of higher infectiousness. I'll talk a little bit more about how we actually do have that, but we do have, what we didn't do for COVID was, I don't think we really leveraged super spreading in terms of thinking about our control policies at all. Sure, the lockdown helped. The lockdown was a little bit more of was a very blunt instrument, but we may have been able to do better if we thought carefully about how to control super spreading rather than worrying just about, just locking everyone down. Now, case fatality rates. There's always been a myth that India has lower case fatality rates than the rest of the world. Not true at all. We have pretty much the same pattern as anywhere else. The case fatality, the exposure, as you see, if you're in a higher age group, much higher chance of a hazard ratio into infection, especially in the 85 plus age group. There is a higher risk of being infected if you're male. And this is all from the early days of the pandemic. And then, of course, as the testing dates went on further, this is time to death. This is not infection, it's time to death. And of course, your risk of dying also greater if you, decreased as the time went by, because medical practice became better and we were more able to, control the infections. And of course, Tamil Nadu also did better than Andhra Pradesh, did worse than Andhra Pradesh because the infections were earlier in Tamil Nadu than they were in Andhra Pradesh. Now, case fatality ratios, not very different from the rest of the world, about 2%, 2.06 in our population across all ages, and higher again for males than for females. If you looked at it by age group and we compared a bunch of countries, this is again early in the pandemic, what we found was India did better in the 80 plus population, and perhaps also in the maybe in the 70 plus population to some extent, possibly because of a survivorship bias. people who are above 80 or above 70 in India tend to be healthier because they survive to that age than people in these other comparable countries. But if you came down to the below 60 population, case fatality ratios in India were actually much higher than in other countries, significantly higher, because we have populations that have high rates of hypertension, diabetes, other risk factors. And therefore, if you took it overall, we didn't do much better than other countries. In fact, we did worse in many age groups. Now, we had very good data from Madurai, where we were able to dive deeper and do things much more carefully, because Madurai had a very unusual program that was not found anywhere else in the world. In Madurai, they had a process called fever clinics, where the government was actually sending people out, door to door, and they were collecting data, prospectively. So they were looking at people who were likely to have been COVID positive, either because of exposure or, elderly populations. And what they did was they did prospective testing with RT-PCR, about 440,000 tests for the period that we were looking at, and about 15,000 infections were identified. And what they did unusually for other, compared to anywhere in the world, is they were capturing chronic comorbid conditions as part of routine intake, whether you were COVID positive or not. Wherever people were looking for chronic diseases, they typically did that after they tested positive. But this Madurai data is unusual in the country, in the world, because anyone who was tested for COVID under this program was also checked for diabetes and hypertension and other diseases. All that data was captured, and of course some of them were COVID positive and some of them were not. And this allowed us to actually look at the difference in outcomes between people who had comorbid conditions versus not. Previously we only had the comorbid condition information for people, like I said, who had actually tested positive. We also had seroprevalence data, which was based on a cross-sectional study that was done across 38 clusters in Madurai in the latter part, in the last 3 months of, in October, November of 2020. Now, what do we find? We find that the first is by test for indication. Why are people actually getting tested? Now, the pink is mostly if they have symptoms. The yellow is if they've had travel. The green is if they've had known contacts. Most people, until about September, were getting tested for some of these reasons. Now, after that, the gray starts showing up, which is they were getting tested for unspecified reasons, which might have been that, they needed to go to work, or there was some other reason why they needed to get positive, to get tested. And what you see, of course, is that people with symptoms were the most likely to be testing positive compared to all of the other sort of categories. Now, we look at predictors of having a positive RT-PCR test, and what we find, as we would expect, is that compared, to the population of 20 to 24, which is the reference population, people are younger, less likely to have a positive RT-PCR test, and people older, more likely to have a positive RT-PCR test. And you can see this with and without symptoms. So the red is with symptoms, and the blue is asymptomatic. And what you see is that obviously if they were symptomatic, they had a greater odds of testing positive, something that you might actually expect. Now, if you look at what symptoms predicted infections, again, very useful information, because it tells us, okay, what do we really look for in people who have COVID? And fever alone was predictive. But if you had, if you also had fever with pharyngitis, rhinitis, myalgia, these were even more predictive than having fever alone. Now, cough and difficulty breathing was not necessarily the most predictive of actually having an infection. So what we really should have focused on, like Madurai did, was really people who had fevers. And that gives us a lot of, with the fever, you can see the adjusted odds ratios, climb up a lot compared to the without fevers. And this was really, really helpful information to have. Now, comorbidities predicting infection. Now, you would think, why does a comorbidity predict infection? Two people are presenting, same risk factors. One person is more likely to have tested positive for COVID. simply because they were diabetic or hypertensive or having a respiratory disorder. This had not been observed previously before the study. The idea that comorbidities predict infection itself now, and we were ourselves a bit surprised by this. But there are, sorts of medical reasons why this might be the case. And one might be that people with diabetes or hypertension or respiratory disorders they probably are exhibiting a higher viral load for other reasons, and therefore they get picked up as being positive in an RT-PCR test, showing that it's not just risk of mortality that is associated with comorbidities. Your risk of infection itself was predicted by the comorbidities. Now you can see this same thing with and without comorbid status across the different age groups. We'll just focus on the males, for instance, and you can see that the gap between the with and without comorbid status goes up a lot by age. So comorbidity doesn't operate on its own. It's interactive strongly with age as well. So if you're in the older populations and you are comorbid, then much higher chance of dying. Of course, you can look by day from days of tests, and for diabetes, circulatory disorders, you can see this gap between what you would have without the disorder and with the disorder, and you can see there's always going to be a gap because the comorbidity is causing is associated with the mortality. But you don't really see much of that with cancers. So you see that for pretty much everything else. I'll skip the slide and basically say that when we looked at Madurai and say US case fatality rates, this is the overall mortality observed. This is the mortality amongst Madurai cases which are reweighted by the age distribution. So one of the reasons India may have been observed to have a lower case fatality rate is because the Indian population is much younger. But once you sort of model it as if this were the US population, you can see that the mortality rate in India was much higher than in the US, higher than in England or in Italy or in China or in South Korea. And of course, you can reweight by age and comorbidity distribution as well. And once we reweighted by that, then certainly people in India did much worse than people in the US and for Italy. These were the only two countries where we had this age and comorbidity distribution. But it really showed that, it's really a myth that India performed. I don't even see this as a performance. It's just, natural outcome. I just think that the case fatality rates were high in India, and that is what it is. Now, the effect of the lockdown, lots of controversy about whether the lockdown is useful or not. Our data showed that the reproductive rate was much higher prior to lockdown, and post 24th March, it really knocked down the reproductive rate. It bumped up a little bit during the second phase of the lockdown. But overall, I think that if we had not had the lockdown in Tamil Nadu, we would have had a fairly severe epidemic in those first 3 or 4 months itself. A reproductive rate of 2.5 is pretty large. And you see the same sort of thing in Andhra Pradesh as well. Now, COVID mortality, we also had a study based on death certificate data from Chennai. This was again done with the Tamil Nadu government. And what we found was, yes, there was an excess mortality. So the lines below are the predicted deaths, and this is the observed deaths. So this is what would have happened, and we were using the baseline of data from 2015 to 2019, basically a 5-year period as our baseline, and we were using a 14-day moving average. And basically, you see that the excess mortality is it's high during the first wave. So but you see a real peak during the second wave. Obviously, anyone who lived in India that time experiences quite significantly. It was true for men and for women. It was true across, certainly age groups. Once you cross the 30s, you really didn't see this for the younger populations. You can see that for 0 to 9, 10 to 19, all of these, you don't really see the actual mortality, exceeding the predicted. But here you see the excess mortality starting to climb once you get into the older age groups. And once you get into the 80 plus age group, it's pretty severe. You can see that it's a massive increase in daily deaths. Now, who was affected by COVID? In Chennai, mortality rose significantly during the pandemic, especially in older age groups. So again, the blue is the expected deaths. This is the red. This is actually from Mint, the newspaper. So they do a better graphic than the Lancet does. So that's why I'm showing this to you. Turns out that we also had data on ward level information on neighborhood characteristics, whether they were crowded, lacked on-site latrines, SCSD, on-site water, etc., etc. And all of these cases, the odds of dying of COVID were generally higher if you were in a poorer neighborhood. Now, during the first wave, in some cases, actually, all of these characteristics were protective. In other words, mortality rates were lower than you would expect in the lower SES neighborhoods. But in the second wave, it was significantly higher. So there was a protective effect of the lockdown in the first wave, and I'll show you why that might be the case. But of course, in the second wave, it was all hell broke loose. Now, Tamil Nadu was one of the states which had one of the lowest death undercounts, compared obviously to Madhya Pradesh, Andhra Pradesh, and so forth. And the data from Mumbai also suggested that there might be a lot of missed deaths in poor areas, simply because the reporting of deaths is really really poor. I mean, I have my own personal example of someone who's driving for my mother, and she lives in Chennai, and he died even without a COVID test because they simply refused to give him a COVID test in the place he was living. And once he got one, they refused to record it as a COVID death, and he was only 52 years old. It was just really, it was shocking, but there was a lot of underreporting if you didn't have access to healthcare facilities. Now, last, I'll close with, the big controversies that have happened, although it should not be any controversy from a scientific perspective at all, about, India's overall COVID toll. Now, ratio of excess deaths in these years compared to reported COVID deaths, this is WHO data. Apart from Egypt, India had the highest number of excess deaths compared to reported deaths. I think reported deaths were about 500,000 at the time that WHO did this report, and excess deaths were about 4.7 million. So just about that. So, and in absolute numbers, India's COVID deaths, excess deaths, I shouldn't say COVID, excess deaths during the COVID period were absolutely the highest in the world compared to all of these other countries. Now, we did a study that's under revision right now, and it should be out soon, hopefully. What we did was we had in Madurai, we were lucky to have data on excess mortality because we had good death certificate data. But of course, we also had the mortality from COVID. Again, all of which was measured at quality, I would say, much higher, not just for any low and middle income country, but across, even the world. These are very high quality data. We had deaths across all settings. You see, so this red is the COVID death attribution. The blue is the deaths amongst confirmed COVID cases. So this is a small number. And then you have, of course, the observed excess deaths, which is massive during the first wave. There's a bit of a period when it actually goes down and then, goes up. Now, you saw that during the first wave, there was some bump up in the healthcare facilities, but not a lot. First wave, more of the community deaths happening. In the second wave, you saw that healthcare facility deaths, possibly because, a lot more people did go to the hospitals, but you also saw the community deaths at that period of time. So the second wave, was like a double barrel, both healthcare and community. First wave was mostly just the community. Now, this is an interesting slide because what it shows is by condition, this is the 14-day moving average of excess deaths attributed to various causes. Now, what we were trying to do is to say, okay, you have all of these excess deaths. So say India has, 4.7 million excess deaths. Only 500,000 you're calling COVID deaths. 4.2 million, which is the difference. What do those people really die of? Because then it gives us a sense for what people were being characterized as if they possibly died of COVID. And what we find here is that if you take cardiovascular, cerebrovascular conditions, big jump up in the first wave, but also a jump up during the second wave, and then actually a decline after that. Diabetes as well, jump in the first and jump in the second as well. And again, you see the same pattern. Facility deaths were not as much, but community deaths were really where much of these happened during the second wave, which means a lot of people didn't even get into the hospital in order to be died there. Cancer is interesting because cancer is the only disease where there was a significant excess mortality during the first wave itself, during the lockdown. And this is possibly because people didn't have access to care. But after that, you see that excess mortality from cancer actually decreases. This is a phenomenon that one might call mortality displacement, which is people who didn't have access to care for cancer died during that first wave, but there was some amount of mortality. So these are people who would have normally died, at periods of time, the following year in 2021 and so forth. But many of them had already died during the first wave, and therefore you see a decline during that 2021 early period. Now, you don't see this kind of pattern for other diseases. So chronic liver disease, it sort of bumps around a fair bit. Other non-communicable conditions. Injuries, we're divided by unintentional and intentional. For unintentional, which is basically mostly road traffic accidents, you see that there's actually a decrease during the first wave, and doesn't really change a whole lot during the second wave. Respiratory conditions, other maternal conditions, again, you see a protective effect possibly during the first wave, and also during October, November, December, where normally we would have seen this number of deaths, but we are seeing fewer deaths because the masking and the social distancing and all that stuff probably prevented a lot of deaths from RSV, influenza, and so forth. Other infections in maternal conditions, you don't really see a huge amount, although we would have expected to see some because of people not being able to access healthcare facilities and so forth, but we really didn't see that much. And so this is also we managed to do the association with principal components, or the 15 principal components of ward level deprivation factors. And what you see here is that the early lockdown, certainly you have a positive association during wave one, as we saw previously in Chennai. You see this negative association, but wave two, it's really very high. It's a very strong positive association there as well. So the takeaway messages from this part of the study were that more than half of pandemic-associated excess deaths up to about July 2021 were attributed to non-communicable disease deaths, but 20% of these were actually amongst confirmed COVID-19 cases. What I mean is only 20% were among confirmed COVID-19 cases, and there were possibly far more. Now, cancer deaths more than doubled during the first weeks of India's countrywide lockdown, probably because of interruptions in healthcare delivery. They were not getting their chemotherapy or other treatment. But interruptions in healthcare delivery prior to widespread SARS-CoV-2 circulation that would have happened probably by June of that first year were associated only with a 6%. I say only with a 6% increase in NCD deaths because we might have expected far more. We might have expected that NCD deaths would have gone up a lot because people not getting access to chronic disease care. But fortunately, that did not really happen. The disruption in healthcare delivery during the lockdown was not as severe as we might have expected, which is good news. Also, the increase that we see from NCD deaths was offset by as much of a 70% decrease in infections, all the other respiratory infections going down, and 37% in reductions in injuries. So, those are obviously a smaller proportion of overall deaths, but we had this positive effect of lockdown. So that's what we see here. So I'd like to stop by, thanking you for your attention. Again, my apologies for not being there. I would have loved to meet all of you as well as listen to the other talks. Huge thanks to all of these people. Our first paper in Science actually had two secretaries of health, Dr. Jawar Reddy from Andhra Pradesh and Dr. Radhakrishnan from Tamil Nadu, both as co-authors on that paper, which is unusual for a scientific paper. But everybody really pulled their weight to be able to get the data and the analysis that made those possible. And of course, none of this would be possible without literally thousands of public health workers in Tamil Nadu and Andhra Pradesh who made that contact tracing absolutely a world-class effort. So thank you all for your attention. And this, by the way, is our upcoming Nimai Valley campus facility north of Bangalore, which is where all this work will soon continue going forward. Thank you.
We really don't have time for questions, but we can have one quick question.
Why should comorbidity like hypertension, for instance, increase per se the risk of infection? If I understood you correctly, you mentioned that the infection rate itself increased due to comorbidity. Subsequent development of the disease, I understand, but why the infection per se? For instance, hypertension as a comorbidity.
So when I say infection, that's a great question. And I think I mentioned that this is not something we have full information on. It's a very strong effect that we find in the data. The hypothesis that RT-PCR is really based on a detection of virus above a certain threshold. And there seems to be an association between people being comorbid and exhibiting a higher viral load. It might be because, their immune system doesn't function quite the same way, and therefore they exhibit the higher viral load. So infection, in the way we describe it, of course, is you're being positive in an RT-PCR test. It's possible that people who were not comorbid also were infected, but had a level of viral load that was not detected by RT-PCR. But people who are hypertensive or diabetic have a higher viral load and therefore are picked up by RT-PCR.
Thank you. Thank you.
If I'm right, in one of the slides you showed that the number of reported deaths in Tamil Nadu is much lower than in Madhya Pradesh, for instance. Is that correct? I mean, the actual number of deaths are much more than reported. Now, I'm very surprised by this because, I thought that in Tamil Nadu, most of the things that are done online, of course, much of it is not reported. I'm not saying nothing. The numbers, I'm very surprised that Madhya Pradesh did much better than Tamil Nadu.
That's a good point. I was surprised as well. And in fact, also to have Kerala in that sort of a same mix, that's what we actually found. We just found that this is, on the other hand, I didn't show UP data there. UP actually really, really underreported. And as did Gujarat, for instance, but it wasn't really. We weren't able to really figure out why some country, this gap between excess and reported deaths was so different across different states in India. Now, certainly, Tamil Nadu has an excellent, death certification system. So if you in Chennai, the death certificate data is pretty comprehensive, just like in Mumbai or in some of the other metros. But this, I would love to have your thoughts on why that was the case. It's just what we found, and it was surprising to us as well.
Yeah, the other question is, you said that people over 65, the rate of death reduced. Now, that may be because they were more careful. They were masked and, social distance and so on. So the reason why, people beyond a certain age, the rate of death actually reduced. You showed one of the slides. And this is without comorbidities. Just a general statistic.
I think you're referring to one slide where I showed that actually the risk of infection comes down when post 60. You're right. That could well be one of the reasons why that might have happened.
They're more careful. They don't.
Yeah. That's a good point. That's a really good point.
Let's thank Ramanan again.
Thank you.